Very good evening to all the respected doctors present here. I, Dr. Snehal from the USV medical team, welcome you all for yet another interesting session from CME India Live on a very interesting topic, that is LDL and beyond. Without much ado, I would now like to introduce to you Dr. N.K Singh, sir. Sir is an MD, FICP, FACP, FRSSPI, and Diabetes India, diabetologist and physician from Dhanbad. Sir is the RSSBI Jharkhand 2019-2023. He's an executive member for National RSSBI, ex-governing body member National API, ex-chairman API Jharkhand and CCEBDM, edited Millennium Book of Medicine. He is also the associate editor for Postgraduate Medicine 2021. He has edited monograph on COVID by ICP API 2023. He has written more than 40 national and international publications. He is also the admin and founder for CME India WhatsApp, and he is also the editor for CME India. With this, he is also completed his fellowship from WHO. Thank you very much, sir, for joining us. It's an honor to have you on board. With this, I hand over to you to introduce our speaker and the moderators for the evening.
Good evening. Snehal, can you share the CV of our panelist, today's panelist? So I think let Dr. Sanjib Medhi will introduce Dr. G.B Sattur. I have to only introduce to the panelist. So
okay.
Yeah, so let me first introduce you. So next slide, can you go for the next slide? Technical, yeah. So I have great pleasure introducing Dr. Sanjib Medhi. You see here, he is one of the brightest physician from the Northeast and based at the Guwahati, and he has done 6 years service as a specialist doctor in the Army Medical Corps and 27 years experience as consultant medicine, and now the diabetologist at the Guwahati, chief consultant at that is a Prathysha Healthcare, and speaker at many national and international conferences, fellow of Diabetes India. He has received lots of awards and lots of posts as you are seeing there. So I think welcome Dr. Sanjeev. And
thank you,
yeah, and so our second panelist is Dr. Gyanendra Singh. Can you show the slide? Next one. Yeah, so Dr. Gyanendra Singh has 17 years experience in in treating various complicated cases in the cardiorespiratory medicine, diabetology, and infectious disease. He has life membership of ADA, ERS, IMA, API, and so on. And he is an ex-senior registrar at BJ Medical College and the Civil Hospital, Ahmedabad. He is now based at the Ahmedabad and director of the new Hansraj Hospital, Ahmedabad. So welcome you all with Dr. Gyanendra Singh. Great welcome to you, and thank you all.
Thank you.
Both. So Dr. Sanjib Medhi, can you now introduce with our today's speaker and the subject, and then we can later on go for discussion after the presentation.
So thank you, Dr. Singh. Thank you for CME India for organizing this wonderful program, a very pertinent program which we'll be discussing today on the lipids, which I think is the hallmark for any intervention, be it primary or secondary, as far as cardiovascular risk reduction is concerned. And to enlighten us on this topic of today, we have Dr. G.B Sattur. He is a senior physician and diabetologist from Hubli, Karnataka. He received a prestigious Dr. B.C. Roy Award in the year 2018 and is a co-author of Consensus on Lipid Guidelines. He's an expert panel member of Hypertension Guidelines. He spoke in many national and international meetings, and he also wrote in many international publications. So we have a host of other honors conferred on him, and he was also conferred the Best Speaker Award in International Cardiovascular Conference in Nepal in the year 2019. So welcome, Dr. Sattur, and all our faculties and all our audience today will be enlightened by today's talk of yours, which we will be delivering now. So over to the organizers for the next program.
Yeah, good.
Is it? Are our slides visible? Yeah.
Yes, sir. Fine.
Yeah. At the outset, thank you, Dr. Singh, Dr. Medhi, for this excellent evening, and also Snehal from USV for arranging this evening. And as usual, it is always a pleasure to be on Dr. N.K. Singh's platform because it's always active, either on the WhatsApp media or on the videos. So today we straightway go on to this cardiovascular risk beyond LDL cholesterol. There has always been lessons that the LDL is causal for cardiovascular disease. And also, we know that why this is a primary target, because it is causal for CVD, it's a primary target. While cholesterol is essential in the body for cell membrane and formation of sex hormones, excess cholesterol, especially LDL cholesterol, would really cause havoc once it gets deposited into the intima. So LDL, why LDL has been causal? Because many studies have been done on LDL, because there are many other molecules that contain the atherogenic ApoB. But why do we talk of LDL? Because that is easily targeted in view of observational studies, Mendelian randomization studies, randomized clinical trial, and animal experiments. Because LDL is causal, automatically by default, it becomes a primary target. You can see that in many patients, you know that statins are the root for at the base of the pyramid in the management of dyslipidemia. And probably this is about, say, 10, 15 years ago, statins were the only molecules which had maximum number of clinical trials. But in recent times, there are many drugs. So statins are well proven, and along with the pleiotropic effects, which are getting enlarged even month by month in a way. From this slide, you could make out that even in patients who are treated with statins, may it be secondary, may it be primary prevention, you could see that statin-treated patients in the lighter blue still had some amount of residual risk. Now, what about those who were on intensive statin therapy? Even in the intensive statin therapy, one could see that here the darker blue segments indicate that there is still an inadequate cardiovascular disease reduction, even in patients who received intensive statin therapy. Which comes to the point that the residual risk of ASCVD in statin-treated patients is pretty high, even almost up to 70% of patients. Nevertheless, it depends on the treating physician or the cardiologist, because in view of increasing number of the super specialty in cardiology, many patients tend to go there with even a stable angina, for example, who may not undergo any PCI or any other procedures. Still, we see that many times the proper reduction of LDL does not occur because of the volume that we normally face in our outpatient or in our inpatients. Apart from the LDL, what are other atherogenic lipoproteins that we can think of? One is a triglyceride-rich lipoprotein remnants, VLDL, IDL, lipoprotein little a, and particularly these have a lot of significance in patients who have elevated triglyceride levels or where LDL has already been lowered with statins, like you saw in the previous two slides. Now, it's important to remember this small thing that I have written on a reverse print. Many times we get confused with remnant cholesterol. Why I'm talking about this, a time will come that we'll be speaking more of remnant cholesterol in the days to come, even rather than ApoB or LDL. So remnant cholesterol is nothing but cholesterol content of the triglyceride-rich lipoproteins, that is the intermediate IDL and a very low density VLDL in the fasting state, and sometimes some amount of chylomicron remnant. I think this part of the slide is extremely important to know further what I'll be sort of exchanging some views with you on remnant cholesterol. This is again a pretty older slide, but nevertheless, long ago, it was very well shown the association. For example, total cholesterol may not have much significance, but when it comes to triglyceride, if you remember, some of the seniors who are here with me would remember about 20-25 years ago, triglyceride was more as a marker rather than a risk factor. Even then also it was thought that each 89 milligram increase in TG resulted in 75% increase in the risk for CVD in women and 30% in men. HDL cholesterol, each 1 milligram decrease resulted in 4% increase in the cardiovascular death in women and 5% in men. So this is how the proportion takes place in an individual. Now we come to the non-HDL cholesterol. In the recent times, non-HDL cholesterol, especially in a place where the lipid profile is not done properly or you don't have an upgraded laboratory, it's very easy to go ahead with the non-HDL cholesterol. Now this slide you must have seen this slide on umpteen number of platforms. But one important point to remember here is all atherogenic molecules contain ApoB100. May it be VLDL, may it be IDL, may it be LDL, or may it be lipoprotein little a, except chylomicron remnants, which is ApoB48 from the GI tract. Not much to add here, although as we saw in the previous slide, it has a bit of a contribution to the triglyceride-rich lipoproteins. Now, all total cholesterol minus HDL cholesterol is non-HDL cholesterol. What about the remnant cholesterol, which I said will become a molecule of future? Total cholesterol minus HDL cholesterol minus LDL cholesterol becomes, which means literally it leaves your VLDL, IDL, and to some extent chylomicrons. Now, this is the ApoB containing lipoprotein family. As you already saw, you have an LDL, you have a lipoprotein little a, not much difference between the two, except that this has got an additional segment here. And of course, the triglyceride-rich lipoprotein, also called TRLs, has got IDL and VLDL combination. Now, from the Lipid Association of India in 2020, it was shown that non-cholesterol, usually regarded as a secondary target, for Indians, we thought non-HDL should be a co-primary target. Therefore, after LDL, or when you are not happy to use LDL, when it is not done by a direct LDL estimation, and where you don't use Friedewald equation, you know that you can't use Friedewald equation in people who have a triglyceride of more than 400. There you need to do direct LDL. And 90% of the advanced laboratories and even personal laboratories like mine or many people on stage on the platform here must be doing LDL estimation directly. People don't use that Friedewald equation anymore. And as you know, with triglyceride, which is very commonly high in many Indians, that really doesn't work. Direct LDL works. So after that, you have a non-HDL cholesterol, very easy. And one advantage of non-HDL is you don't need to be fasting. You can't ask a patient coming from 100 kilometers, especially in two-tier town like Hubli, where I practice. 50% of our patients are from surrounding villages from around 150 kilometers. And you can't make them come next morning and say, come on fasting. They have to stay in a hotel. This is not very easy. So I think non-HDL has really come up as a good saver for all of us. Just do the total cholesterol minus the HDL, it becomes non-HDL. And how much is that? Non-HDL cholesterol is always 30 milligram above LDL cholesterol. Suppose in a diabetic, you aim at LDL cholesterol of 70, for example, without any other risk factors, your non-HDL will be 100 milligram per DL. Now, this is the meta-analysis of the relationship between non-HDL reduction and coronary artery disease. And this meta-analysis involved 14 statin trials, 7 fibrate trials, niacin, which is not extensively used now, and even bile acid sequestrants, and including the diet. You can see from this slide here, non-HDL is an important target for CHD prevention. And the most lipid modifying drugs used as monotherapy, which we mean as statins, have an approximate 1-to-1 relationship between percent non-HDL lowering and CHD reduction. What do I mean by that? Just look at the WASCOP study here. If you just come to the WASCOPs here, the second on the right panel, come down here to the blue marker at the non-HDL reduction. Suppose you have reduced by 25% the non-HDL. On the risk reduction, it is 25%. So this is called 1:1 relationship. I think it's also important to realize when you plan monotherapy. But as we go through the slides, the recent advances are not in favor of monotherapy, which you will see later on. This is by the Salim Yusuf, one of the landmark studies, 52 countries, 50,000 MI patients as against 14,000 controls. All in all, the modifiable risk factors, you could see that here, conditions like diabetes, hypertension were pushed away from the ApoB, ApoA1 ratio. And what's important is, since non-HDL measures cholesterol component of all ApoB containing lipoprotein like IDL, VLDL, and LDL, it correlates with the circulating levels of ApoB. ApoB in India, we consider it as, even in many Western countries, we consider it as an advanced lipid profile, along with lipoprotein little a. And something important about lipoprotein little a is you need to do it only once in your lifetime. And the normal age to do is at the age of 18, when the girl or the boy is going on to PUC or some college course. So we used to always mention this on some of the non-medical platforms. I always told the parents that instead of presenting an Apple mobile to your son or a daughter while going to medical college, get the lipid profile, ApoA, lipoprotein little a, lipid profile, and sugar when they are 18 years of age. I think this is what should be the drive home point for all of us attending this talk. Now, this is again a very important Copenhagen general population study. This literally stirred up many issues because this was not just was an 8-year median follow-up. OB and non-HDL are better reflectors of residual risk than LDL cholesterol in patients who are treated with statin. You can see here all-cause mortality, myocardial infarction. One could easily make out that the non-HDL cholesterol definitely stood as a better indicator. And hence, it's pertinent that all laboratories should report non-HDL levels in addition to conventional reporting of LDL and TG for better characterization of residual ASCVD risk and treatment targets. And since many people have popularized this, and I have really taken it as sort of a challenge by default to make non-HDL very popular because it's very easy, practical. So every laboratory should mention the non-HDL reports. Now, what about how do we go beyond LDL? With the NMR lipid fractionation, and we tend to treat the residual risk. Small, dense LDL, we all know that the modified ApoB, this is a modified ApoB, has affinity for hepatic LDL receptor, longer residence time in circulation, easily oxidized, easily enters arterial intima, more readily retained in intima, and atherogenicity is almost is much greater than the large buoyant LDL cholesterol. That is one of the reasons why in many patients, Indian patients admitted to ICU with an MI have a normal looking, say around 120 milligram of LDL, but they have an MI. It is not 200, 160, 180, like in familial, like in FH. So what it means, although your cholesterol level just to see maybe 100, most of them are small, dense LDL. Now, this is another interesting study from the Framingham men. You can see that from here, from left to right, along the x-axis, these are the components of metabolic syndrome. Along this axis, you have got LDL cholesterol. And what is marked in the orange is the LDL cholesterol, and what is marked in green is LDL particle size. You can see that is a real beautiful study. I loved this study. As the number of the metabolic components increase, you could see that the correlation is better with the particles than the total LDL cholesterol. So coming to this, small LDL particles contain less cholesterol than larger, but you can see that because the number of particles are more, this is 100 milligram large, 100 milligram DL, but small, dense, therefore it has more of FOB. It is something like comparing, say, for example, you have 1 kg of stones here, 1 kg of sand here. You can see sand particles are plenty. You can't count in 1 kg, whereas you can easily count the larger stones in the large LDL. And now we come to something about what I was talking about, the remnant cholesterol. Association of remnant cholesterol with joint atherosclerosis and arteriosclerosis progression beyond LDL. So remnant cholesterol is independently associated with both arteriosclerosis and atherosclerosis, and hence RC could be a better or earlier risk factor than LDL for both arteriosclerosis and atherosclerosis. Just to refresh your memory, atherosclerosis is an occlusive disease due to lipid-laden plaques, while arteriosclerosis is non-occlusive remodeling of the vasculature accompanied by loss of arterial elasticity. Now, this is another interesting study. Remnant cholesterol predicts cardiovascular disease beyond LDL and beyond FOB, a primary prevention study. In people who are free of ASCVD, the elevated residual cholesterol levels were associated with ASCVD independent of traditional risk factors, independent of LDL and FOB. The mechanism of residual cholesterol association with ASCVD surprisingly beyond FOB, and potential value of targeted RC lowering in primary prevention need to be further investigated. This is exactly what I was talking about. Probably a time will come when we start sort of notifying remnant cholesterol also in our reports, not just the non-HDL cholesterol. Now, this is very interesting to see. Again, what is the triglyceride-rich lipoproteins? You saw that IDL and VLDL to some extent chylomicron, and HDL is good lipid, LDL is bad, and LP(a) is an ugly lipid. Now, you can see that increased plasma levels of TGRL you see in visceral obesity, type 2 diabetes, chronic kidney disease, and polycystic ovarian disease. You can just see in this slide pathophysiology of TG-rich lipoproteins in the progression of atherosclerosis. If you just look at this slide here on the left side, the triglyceride-rich lipoprotein easily penetrate the intima. And these remnants having penetrated the intima, they are easily taken up by the macrophages, which ultimately leads to foam cell formation after the cholesterol loading into it. Then at the same time, you have plaque formation, and the plaque progresses. Ultimately, the soft plaque would rupture and cause the damage. And this is the lumen. In the lumen, one could see that with the TRL, the lipolytic products also, inflammation, coagulation, endothelial dysfunction through complex mechanisms and through activated platelets. Platelet activation leads to aggregation. And all in all, both in the lumen and in the intima, pathophysiology keeps active all the time with the TG-rich lipoproteins. Now, this is, Now here, if you just look at this slide, on the left, you have got a CRP related to LDL, fasting. On the right, you have VLDL, IDL, again the CRP. Come back to the left one. CRP is only 6% higher per 1 millimole liter of higher LDL cholesterol. Whereas when you come Come to VLDL and IDL, almost like, for example, the triglyceride-rich lipoproteins, you can see that CRP is almost 36%, meaning VLDL and IDL are better markers of inflammation than LDL in a way. And again, this is Italian population, the TG real retrospective cohort analysis, how hypertriglyceridemia is associated with all-cause mortality and atherosclerotic cardiovascular events. And the conclusion was moderate to severe elevation of triglyceride is associated with significantly increased risk of all-cause mortality and CSCVD events, even in a large cohort of low to moderate cardiovascular risk in the real world. You can see on the slide here in the high TG with the ASCVD events and high TG in the overall mortality. The population, the study used almost 158,000 individuals, quite a big study. And they defined high TG as between 150 to 500, and very high TG was defined as more than 500 in their study. So when we come to triglyceride, raised triglyceride concentration are additional causal factors for CVD and all-cause mortality. Inflammatory components of atherosclerosis may be modulated by the triglyceride-rich lipoprotein, leading to unstable plaque, which easily ruptures. Elevated triglycerides associated with the higher CV events and increased mortality. You just now saw a large Italian cohort at low to moderate severe risk. In a large statin treated patients, which you saw in the Copenhagen population, elevated triglyceride-rich lipoproteins were associated with high-cause mortality and MI, meaning triglyceride-rich lipoproteins and the remnants are gaining much importance. Inspired by the combination of treatment for hypertension, some of these authors thought that why not we combine lipid lowering agents, and with that, patients who have clinically manifest ASCVD who require greater LDL-C reduction than any additional therapy alone, think of simultaneously adding two agents to reduce the risk of recurrent events more rapidly. When you add two agents, to some extent, it covers the additional risk that there is there or residual risk beyond LDL. Combination with high intensity or maximally tolerated statin with ezetimibe, and even you can think of PCSK9 when you try to combine. So it's time for us to move to combination therapy as a first-line approach in the management of dyslipidemia, especially in patients who have high and very high cardiovascular risk. This is one of the graphs that you can see from Peter Libby, excellently demonstrated. With statins, we come to the oral combinations, so many lipid therapies. Then you have got the monoclonal antibodies, then you have got antisense oligonucleotides, then small interfering RNA, vaccination about 1.5 years now into trial. So there could be a time when annually given vaccine could reduce the ischemic burden or cardiovascular disease burden. And of course, gene editing. I really don't know how useful gene editing for life could be, because you never know what would be the other side effects once you start modifying the gene. But nevertheless, this is what is going to happen in future. Now, the secondary target by Indians should be regarded as non-HDL as a co-primary target, as described by the LAI. And of course, you have got LPA for a reduction beyond LDL. PCSK9 inhibitors have come up in a very big way. You can see here, right from earlier time, the clinical milestones are in the green. As you go towards the later years, from the 4-year trial, which used evolocumab, and then Odyssey outcomes with alirocumab, you can see that then came the inclisiran. All these compounds with PCSK9 and which were primarily designed for familial hypercholesterolemia. Some of these trials were in those people. Now, what are these PCSK9 inhibitors? Most significant advances in clinical cardiology are the PCSK9 therapies. You can see that here. PCSK9 is expressed in the liver, intestine, and the kidneys. They form a complex with the LDL receptor, LDL particle, extracellular domain, and they undergo clathrin-mediated endocytosis, acts as a chaperone. By chaperone, we mean, for example, this is very commonly used. It began in United Kingdom. Whenever a male doctor is examining a female patient, the accompanying nurse, as you know, is called chaperone. Chaperone is something carry along, something that there is in association with, results in lysosomal degradation of the entire complex, where there is LDLR goes to a decreased LDLR, recycling, fewer liver cell surface, LDLRs to process LDL, and you have increased circulating plasma LDL with PCSK9. When you inhibit it, naturally you would expect the PCSK9 to be inhibited and LDL would be reduced. First member is alirocumab, FDA approved in July 25, basically in heterozygous familial hypercholesterolemia, and of course, patients with atherosclerotic cardiovascular disease. I don't want to go into the details. To begin with 75 milligrams subcutaneously every 2 weeks, and later on increase it to 150 milligram. And of course, you have got evolocumab, another drug also approved, and you can be used as an adjunct to diet, again alone or in combination with other lipid lowering agents like statins, and also used in heterozygous familial hypercholesterolemia and homozygous. Of course, more severe may even need lipid LDL apophyresis in some patients. Evolocumab, again, is a subcutaneous injection. I don't want to go into the details of this. And this is some of the various strategies. So we just saw some monoclonal antibodies. Then you have got small here, siRNAs, small interfering RNAs, twice yearly injection. Efficacy is shown here. Oral peptide derivatives, antisense oligonucleotides, administered orally or subcutaneously, vaccines we just saw, and then also you have got the CRISPR based editing, which would ultimately go on to even editing the DNA. Inclisiran is a long-acting synthetic siRNA. This is very tissue-specific. These carbohydrates bind to abundant liver-expressed asialogoglycoprotein receptors, uptake of inclisiran specifically into the hepatocytes. So, however, things can go wrong when you use PCSK9 inhibitors. Allergic reactions are itis, although it is very rare. Patients, we have to really keep an eye on vasculitic manifestation. Liver enzymes can rise. There could be some musculoskeletal symptoms, and one could have neurocognitive symptoms. And then, of course, we are aware of icosapent following a reduced trial potentiated by evaporate trial. Now, icosapent is nothing but an ester of is an ester compound, icosapent and EPA, ester of EPA. Icosapent is available in very much in India. 4 grams per day is the dose. And icosapent has a great reduction ability for triglycerides. It is also antiplatelet aggregation effect, anti-inflammatory, antioxidant effect, reduces circulating remnant levels of remnant cholesterol, stabilizes the atherosclerotic plaque, reduces hepatic production of VLDL, inhibits hepatic triglyceride synthesis, increased mechanisms of hepatic beta oxidation, reduction of blood pressure. So icosapent is very much a good drug as an add-on to statins or even ezetimibe with statin and with icosapent. Of course, bempedoic acid is very much available in India. It leads to increased expression of LDL receptors, increased LDL lipoprotein plasma clearance. It's a prodrug, of course, for oral administration with intracellular activation, activated in the liver cell and to some extent in the kidneys. And we know that it is absent in adipose tissue, muscle cell. Therefore, unlike statins, the potential myotoxic effect of bempedoic acid is limited. It is now approved as a lipid-lowering drug in combination with diet, with statins, with or without lipid-lowering drugs. In mixed dyslipidemia, statin intolerance, or wherever statins are contraindicated. One thing is, when you add to statin the bempedoic acid, maybe one could reduce the statin dosage and add bempedoic acid. Now, this is one of the slides that one would need to go bit sort of more watchful to watch this. Now, these are all newer molecules. How did they come up? The catabolism of triglyceride-rich lipoprotein mediates enhancement of HDL with phospholipids. And when the phospholipids are added to HDL, that increases their ability to promote efflux of cholesterol from the foam cells and thus reduces atherosclerosis by enhanced reverse cholesterol transport, which is done by the HDL. Many compounds are coming up. They are already in phase 3, phase 4 trials. Some of them are not yet recognized in the United States. Microsomal triglyceride transport protein inhibitors. This one of the compounds is lomitapide. The triglyceride transfer to ApoB is inhibited. VLDL synthesis is inhibited, thereby decreased VLDL, decreased chylomicrons, and finally decreased plasma LDL. Dosage again available as capsule, very much used in some centers, only even in the US. Adverse drug reactions, it causes hepatic steatosis. And another group of compounds is antisense oligonucleotide against ApoB. The drug is mipomersen, very well known. FDA approved it in 2013, and hybridization of mipomersen to the target ApoB mRNA creates a substrate for RNase H1, the decrease of the ApoB mRNA level and the production of ApoB protein, which reduces the ApoB. Dosage, this is for subcutaneous use. It comes in pre-filled syringes. Dosing schedule, we don't need to go into the details. Quite a bit of adverse drug reactions, mainly the steatohepatosis. What about the ApoA1, which is an important component of the HDL cholesterol? What about the mimetics? These are very much in an experimental stage. High serum level of HDL is well-known protective factors for ASCVD. ApoA1 is a major apoprotein component of the mature LDL. ApoA1 takes cholesterol from macrophages in atherosclerotic lesions via ATP binding cassette A1, which is the root processing in reverse cholesterol transport. This is the latest classification by the Lipid Association of India, which introduced the extreme risk group beyond the very high risk group. But whatever the risk, whether you are in low risk, moderate risk, high risk, very high risk, or extreme risk, where there are again two categories. Category B has a polyvascular disease, and category A has cardiovascular disease with more than any one feature of very high ASCVD. What is common to all the groups is lifestyle. Without lifestyle, it is extremely difficult to go even reduce the residual risk. Lifestyle has to be part and parcel of the management of dyslipidemia. This is one of increasing waistline. Diabetes is becoming very common. This I happened to read this on my way to Amsterdam almost 15, 20 years ago. There was a time when this sort of a figure of 8 was said to be very enviable physical structure for women. But with the modern times, most of the women are rectangular. And that is the diabetes. Of course, men are no exception with the pot belly, with increased visceral obesity. All in all, we are now into diabetes. There is one very nice story in Mahabharata. about this hourglass Fiji. Draupadi was bathing in a river, and she was accompanied by her female, what do you call them, guards or whatever, about half a dozen of them. And all of them, Draupadi was one of the most beautiful women in Mahabharata. And when she was bathing, all the other girls that were also bathing with her expressed, wish I was a man, was the expression, meaning there has always been some amount of the physical touch to the feminine gender, which now, unfortunately, as I said, is becoming more and more rectangular. And to add fuel to fire, the myocardial infarction, especially in postmenopausal women, is undertreated even in the West, let alone in India. So this needs to be really carefully looked into. And of course, lifestyle includes the diet. Red meat and white meat are equally bad. And today morning, I got this piece from American Journal of Clinical Nutrition, multi-ethnic study of atherosclerosis. When adjusted for body mass, BMI, the intake of unprocessed and processed red meat was not directly associated with any markers of inflammation like CRP, thus suggesting that body weight, or more likely adiposity and not red meat, is potentially the more important driver of whole body inflammation, which has been shown in RCTs. In other words, although red meat, they say, is not really that damaging, I think one should be very careful in Indian setting, because we come into the low or mid-income countries, and red meat, whatever in any form, probably needs to be restricted. And of course, exercise is again hardly taken up by more than 50% of young individuals in India. And fortunately, 60% of the Indians are young people. So we really need to impress upon them the lifestyle along with the cholesterol checking time to time. Exercise is very important. Now, is there an alternative to exercise? Of course, there is. Best alternative is hospitalization with some sort of chronic non-communicable disease. Of course, there are the last slide. There are always exceptions to the rules. All of you have seen the James Bond movie. This guy is Sean Connery. He used to smoke 70 cigarettes per day during the shooting of Dr. No. So you would expect him to have premature death, but he died at the age of 90. Therefore, today morning only I saw one patient who came to me 5 years after diagnosing the diabetes and hypertension. He had a stent placed in. He said his wife brought him today. And he said, "Doctor, I am fine. I know when I get unwell. I know when to come to you." And he didn't come for 5 years. So these are all exceptions, unfortunately, like Sean Connery, but not many of our patients. We need a right follow-up at all levels. Thank you very much.
Thank you, Dr. Gururaj, for taking us through the wonderful journey of lipids. In fact, you touched upon the very basic nerve of lipid management, in which till now many of our doctors were more concerned with the LDL part. But now time has come to think beyond LDL, as you have properly highlighted the non-HDL cholesterol, and of course the triglycerides and other atherogenic particles which are there. The remnant cholesterol, which you have told, is also very important. So things are very bright now, and we must think beyond the lipids only. We must think beyond the LDL only. And the non-HDL, which you have rightly told, that can be checked in the non-fasting state also, holds very pertinent for our patients who come to our checkup and whom we can't say that you come empty stomach for a lipid profile. So we have few questions in our chat box, and to take us through. So the first question is from Dr. Snehal Bansode. He has asked that whether the patient fails to achieve the 2019 ESC guidelines of LDL goal, could CV risk underestimation, underutilization, or combination therapies be contributing factors? Yes, Dr. Sattur, can you take up this question? The patients who fail to
Yeah,
achieve
I mean,
the
yeah, whatever the guidelines, I mean, you know that they keep changing from year to year, and some of them do it every 2 years. One thing to realize, guidelines are there, but when you're treating an individual patient, you really need to look into other aspects. From that point of view, I think combination you saw, at least in high risk group from day one, say for example, statin with ezetimibe makes more sense than using a very higher dose of or intensive statin therapy.
So means you mean to say that now time has come for a combination therapy in which
Yeah.
in high risk patients, not in all patients, but patients who are of high risk, who have increased risk of cardiovascular death, who have history of cardiovascular disease in their family, then in those class of patients we can go in for combination therapy with statins, of course, is the cornerstone, and add on to those therapies like ezetimibe or bempedoic acid, as has been rightly pointed out. So the second question is, how low LDL can cause atheroma volume regression? A very subjective type of question. Can it be quantified?
No, I didn't get the question.
He has asked that how low LDL can reduce the atheroma volume regression in the arteries.
Now, once you try to reduce LDL in a way that when you try to reduce LDL, you reduce the very receptors on the liver. So that's how it happens that especially the statins and other drugs work in such a way that by gross reduction of LDL, again depends on other factors, whether patient is in high risk or in extreme high risk. But ultimately, LDL-C reduction is through many pathways, but pleiotropic effects of statins are very important rather than reduction of LDL, because you use statins on day one of MI. It doesn't reduce cholesterol in one day. It takes around 6 to 8 weeks to reduce cholesterol. So it is those pleiotropic effects that are equally useful rather than just reduction of LDL.
Yeah, Dr. Sattur rightly pointed out that, see, any statins which needs to be given, statins has to be a long-term therapy. We can't expect an overnight result by giving statins. So patients who, I am just forgetting the name of the trial, which has rightly pointed out that statins continued for years really give the result which we want. So atheroma volume, if suppose a patient has already developed atheroma, you are putting him on statins on long-term therapy, then we are looking more for the pleiotropic effect. We want the plaque stabilization. We want the other inflammatory markers or the all those to come down. So that's very important. It is not that the plaque will regress. The plaque will stay. It can only be stabilized by the use of statins. So that's very important. And this, suppose you use statins for a very long time, definitely some amount of regression will occur, but don't expect the plaque will disappear. Am I right, Dr. Sattur?
Yeah, absolutely. Because plaque regression has been shown with rosuvastatin by the intravascular studies, definitely shown. But that is not action. That is not what we need to achieve
Yes.
with LDL. Yeah.
That's very important. We want the plaque to be stabilized. A plaques will be there in the body. Everyone has got some plaques. Maybe the numbers can be different, but we want the plaque to be stabilized. We don't want the plaque fracture over there. And so the acute events can be prevented by the use of statins, if you see from those point of view. So the most important point is that to stress the patients that they should continue statins for a long period of time. Then only they will get the benefit. It is not a short-term therapy. So the third question, we have very wonderful questions. Thanks, whoever is posting it. And this is bringing up the discussion well. So can long-term treatment with twice daily siRNA, twice yearly, inclisiran, help with sustained reduction in LDL cholesterol? Also your comment on safety profile.
Yeah. Now the small interfering the RNAs and these drugs, of course, I mean, like inclisiran, and not yet marketed in India, but definitely it would be an add-on to statins, especially in the extreme high risk group, because that's fairly a new drug. And as I showed you, some problems can occur with inclisiran, but I wouldn't advise it unless you are able to follow the patient on a regular basis to use inclisiran. Not yet available. Probably Novartis is likely to market it by December. Hopefully it should be. It was somehow government of India refused to allow, probably Snehal knows this, refused to allow inclisiran to be marketed in India. So till then, I don't think it will be very hypothetical to discuss on it.
Yeah, I would just like to add to this that one of the most, which many of us don't know also, and I was just reading it up, I came across that one of the side effects of the use of statins is that it causes a 10 to 20% increase in the level of lipoprotein small a. Am I right, Dr. Sattur?
Yeah, you are right. You are right. You are right.
And in those class of patients, we don't have any molecules as of now which really brings down the lipoprotein little a. So in those
PCSK9, yeah, PCSK9 is one of the drugs that could be used for LP little a. Another one is niacin, but niacin is not really a worthwhile drug.
Inclisiran also has been shown to reduce by almost 90 to 80%.
Yeah. Yes.
Drugs. So use of statins can cause an increase of around 10 to 20% in the level of lipoprotein little a, which is very atherogenic, we all know. And we don't have any molecules apart from one which Dr. Sattur and this PCSK9 and inclisiran, they have shown to reduce the level by almost 99%. But yes, as rightly told that India is still awaiting the molecules. So till that time, I don't think we have anything to say on this.
And it's important to realize that when we do LDL, about 10 to 15% of the LDL that we check in the lab has got a LP little a, about 10 to 15%. So it's important to realize you're not just measuring LDL. It also measures to some extent some LP little a.
Yeah. And one of the most important disadvantage of use of statins is that it converts the small dense into larger LDL, which is less atherogenic.
Yeah.
So that's a very important. So the statins, apart from the numbers, they have got more of other pleiotropic effect, a host of pleiotropic effect, which really manifest if you use it for a long term after years of its use. So coming on to the next question.
In fact, I'm told Eugene Braunwald probably likes to flaunt 20 milligram LDL level in him. I don't know if it is an anecdote or it is a truth, meaning that very low LDL are really not that dangerous like once thought, that it leads to dementia, cognition defects. Many studies have now shown, especially in LAI also came up, and European guidelines to less than 55, they went up to LDL of 40, and extreme risk LAI went up to 30, which also has been seen in some of the recent trials. And in some people, some have gone up to single digit LDL cholesterol. And it is said that they aren't going to cause any ill effects on either nervous system or on muscle or on liver functions. But there is some subset of statin intolerance. Yeah.
Dr. Sattur, you have touched a very raw point, a very raw nerve. In fact, I must say that I have recently come across one important side effects of statins, which I don't know whether it is right or wrong. But is the use of long-term statins associated with increased risks of dementia in the older age group? Because we all know that it affects the cholesterol mechanism.
One of the theories is that in people where you found dementia, these elderly people were anyway going to get either Alzheimer's or multi-infarct dementia. So there they didn't say it was statin that caused. And beyond the age of 75 years, you know that statin really one wouldn't like to use in a very intensive dosage like 40 milligram rosuvastatin after the age of 75. It is practiced in some European countries, even following a procedure like stenting, for example. They wouldn't like to use 40 milligram rosuvastatin, because in those who are susceptible to develop Alzheimer or multi-infarct dementia, you start blaming statins. But there are no studies to indicate directly that it is implicated in cognition defects.
Like statin was implicated also for low testosterone level, which didn't hold the ground. Which didn't hold the ground. So I hope the same thing occurs with dementia, and statins which had been blamed for the higher incidence of dementia in patients who are living longer. Maybe that also turns out to be wrong, because we have a wonderful molecule which we really need if we really want to bring down the cardiovascular risk factor. So the last question, which quality metric measurement would you use for LDL-C? Of course, the direct measurement. Yes, Dr. Sattur?
Yeah, of course, because Friedwald equation is not really used, number one, for the simple reason high triglycerides are very common in the Indian population. And beyond 400 milligram triglyceride, Friedwald's doesn't really work. So, and now direct LDL estimation is order of the day, even in periphery. We use direct LDL in our laboratory here. So when I can use in Hubli, I think that should be order of usage all over the country in major towns.
Dr. Sanjeev, there are very interesting questions. Dr. Gyanendra Singh, can you see those questions? Can fenofibrate lower mortality, coconut oil, ghee, butter, your advice? So first, what's your opinion on coconut, ghee, butter, and about the fenofibrate? Because they are also asking, can fenofibrate lower mortality?
Yeah, it's a good question. Yeah, you just saw recently that pemafibrate miserably failed in giving any good results. And because of ill effects, it was discontinued prematurely. Fenofibrate somehow has become a villain in the spectrum of lipid-lowering agents. To reduce triglyceride, especially when it is more than 400, fibrates can still be used. The only problem with fibrate, when you use it with statin, you increase the muscle and the liver enzyme risk, number one. Number two, there are no cardiovascular outcomes with fenofibrate, with whatever fibrate that you are trying to use. In the real world practice. But we have got to use fibrate at least to prevent pancreatitis in people whose triglyceride is more than 600 or 500 or even 800. Some people say 800. But some books say you need to use reduced triglyceride beyond 500 with fenofibrate.
Even, sir, fenofibrate has got some role in reducing the severity of diabetic retinopathy also. Yeah, and correct. It has gone approval in Australia for that also.
Absolutely.
Sir, another question, sir, regarding these oils. Which oil you recommend? Coconut oil, ghee, and all this.
Yeah, this is a good,
very common practical problem.
Yeah, this is a good question. I think the current way of looking at oils is keep 2 to 3 oils at a time in your kitchen. One oil, because you get different proportions of mufa and pufa in each oil. Some of the oils that are preferred for Indians are mustard oil, followed by the canola oil, and sometimes the till oil, what you call eldeni. I don't know what is called in Hindi for that. These are or even groundnut oil. They are predominantly monounsaturated. And of course, olive oil. Now, virgin olive oil is available in India, and the processed olive oil is useful for frying also. Otherwise, you know that olive oil is more for dressing rather than frying. Extra virgin olive oil is now available, but don't prefer the processed oil. You need to go to the oil which has been taken out from the seeds directly. I think that is one of the best ways of using
the cold pressed oil.
Yeah, rather than going through 7 to 8 stages of chemical processing of the oil. Of course, it may smell odd when you take this organic oil, but I think that is the best way to use, not the oils that are available in Reliance or somewhere.
Yeah, Dr. I always say
you should think of. cold pressed oils, in other words.
Yeah.
But regarding this ghee, one question is regarding ghee and butter. What's your advice? Ghee and butter. Ghee.
Yeah, that's again a very good, very good question. Per person, the oil allowed is 15 ml, which is 3 small teaspoon or 1 bigger spoon. If you are using 15 ml per person in the house, you are allowed 1 teaspoon ghee every day. Now, this is not based on any on allopathic studies. This is purely on thousands of years of usage in India, where the Ayurvedic proponents always prefer this. So what we concluded in LAI was allow ghee, because although it is some amount of significantly a saturated fat, I think 1 teaspoon probably does no harm. The remaining 2 teaspoons you should use probably a more unsaturated like groundnut or till oil.
Should be taken in moderation. Everything can be taken, but it should be taken in moderation. Not the dose should not be exceeded.
Sir, one last question from me. I am practicing in Gujarat, and most of the people here are vegetarian.
Yeah, Dr. Singh, you are asking.
Yes, I am asking some questions, sir. So, what about? Can you hear, sir, properly?
Can you repeat the question? I'm not able to hear you.
Yeah. Sir, I am practicing in Gujarat, and here most of the people are vegetarian. Patients are vegetarian. So what we are going through, the most of the patients, their LDL remains normal, but they are having hyperhomocystinemia. So I am talking about beyond lipid. What are the reversible or modifiable risk factors of coronary artery disease beyond lipids?
I agree, but somehow,
lipids.
But somehow
like homocysteine and CRP, HSCRP, sir.
Now, there was some segment of HSCRP more than 2, less than 2, rosuvastatin being used, which is said to reduce the inflammatory markers that include CRP, interleukin 6, interleukin 2. All these are reduced by rosuvastatin, no doubt about it. But one has to remember, in vegetarians that you were talking about, most of the vegetarians think that the cholesterol may not be high. Lean individual thinks his cholesterol is not high. So everybody has to undergo lipid profile. This is another point what I wanted to make. You don't necessarily need to have higher BMI, more than 23 or 25, to get your lipid profile done. Even if you are very thin, your LDL can be 200. So that's how I think is probably important.
Sir, what about homocysteine, sir? Homocysteine, hyperhomocystinemia.
Somehow that has, except Thyrocare and some other firms do, the homocysteine levels. It has not really received that much of an attention. I hardly read it in any of the texts. In this morning also, I showed that red meat reference, where they said you can eat red meat and still don't worry about LDL, worry about BMI. But if that is to increase BMI, that itself is a risk factor. In Indian, visceral obesity is a risk factor. And adolescents are putting on weight in Indians, as you know. 13, 15-year-old girls are putting on more weight than the boys. So these are all many, issues where just homocysteine probably got neglected in a way.
And sir, what about colchicine, sir? Colchicine.
Colchicine again is coming up. There's again a very good question. Some of the cardiologists are into it, at least for secondary prevention. I don't know its role in primary prevention.
So many a time you come across patients who are very resistant to treatment. Suppose regarding high triglyceride level, we give them the full tolerated dose of statins, we give them fenofibrates, we even give them bempedoic acid. Then also their triglyceride doesn't come down.
You can add saroglitazar. Although saroglitazar doesn't have cardiovascular outcome results, mainly an Indian drug, I think saroglitazar is very impressive now. And you know that it is indicated for NASH also. in recent times. And quite a few patients of diabetes have NASH. So if you have got a very high level of triglyceride, I make a policy these days, along with fibrate in a small dose and small dose of statin, I add saroglitazar. Responds extremely well.
Well, sir. Any other questions, sir?
I think Dr. Medhi, I think any question left, Dr. Snehal? Can you see?
Yes, sir. There are just two questions, sir.
Can you read?
Yes, I'll just read it out for you. So your view on a J-shaped association between LDL cholesterol and high sensitivity C-reactive protein levels.
You saw one of the slides there where we showed that LDL cholesterol on one axis and increase in the CRP on the other axis. You saw that. With LDL, the CRP is hardly around 6% in that, while with VLDL and IDL, the remnant cholesterol, it was 36% CRP. So naturally, these remnant cholesterol or remnant cholesterol in any form is probably more in CRP pathophysiology than LDL per se.
Thank you, sir. That brings us to the last question for the session, sir. Should we go ahead with early combination therapy with a high intensity statin and ezetimibe and escalation of lipid lowering therapy with either bempedoic acid or PCSK9, sir?
It has been taken up, I think, already.
I think we already, this question is already answered.
We already answered this question.
I think this was an excellent session today, sir. I have learned many new things. Dr. Medhi and Dr. Gyanendra, you will agree. Sir, I think the new drug is pentylethyl. That is, I think, making a bit of wave in India also because it has become available and affordable. So what do you see the future of this molecule?
Icosapent definitely, if you are not happy to use fibrates, you could use icosapent 4 grams per day, 2 gram BD.
What's the trade name, sir, of this molecule?
Say it again.
What's the trade name?
Trade name, I don't know. I just write it as icosapent.
Sanjib, there are 3 or 4 pharmaceutical biology lines it. 30, I think 30 rupees is one tablet is coming up.
I'll put it on CME India tomorrow, the trade name. I'll put it tomorrow.
I think that there is also one thing I would like to tell you that my patients having high triglyceride level coming to me, and they have also high uric acid. In those cases, I read the literature and I got few papers that only just by reducing the uric acid and not using a statin or any anti-lipid drugs, I was really surprised that the triglyceride level came down when I only used this Fevistate. So I think they do aware about this combination of high uric acid and triglyceride.
Not really, but one thing I'd like to mention, when you come across a patient with high triglyceride, secondary causes like hypothyroidism needs to be ruled out. And if in case of diabetes, controlling the diabetes to an HbA1c of around 7 itself corrects triglycerides to a great extent. So I think these factors probably need more attention rather than harping on fibrate or icosapent or saroglitazar. So I think that's a...
Sanjay, what I want to make to a point that there is a link between the hyperuricemia and the high triglyceride level. So there we don't have much studies, but please look for that. And the second thing that once I did the Navratri fasting, and I was surprised that my LDL was 70, and my cholesterol was okay, my triglyceride was okay. And when I did it, just my interest that what happened to the lipid profile, and after Navratri, it urged all the levels like triglycerides, LDL, everything went high and high. So I was really surprised. So I researched the literature, and then only I got one paper which explained it. I think I will have just forgot that paper now. But are you aware for what happens with the fasting? I think
I know. Yeah, true. Yeah, true. Yeah, and I think, and most of us really do not get lipid profile done. It was good that you got it done. I think we should do that a practice and probably make a drive that all doctors should undergo lipid profile and at least LPA, which is only once in a lifetime. And how many of us have got done? And I got it done recently. Not that I had any problem, but I thought I better know it. But I think from college onwards, we should try to do that. Whoever comes to the clinic, get one LPA done. Not done routinely, but many Lal Path Lab or some such labs do LPA.
So I think we had a very wonderful session today. So I think lastly, Dr. Gyanendra Singh, any take-home message from you, and then Dr. Sanjib Medhi, and then Dr. Sattur. Dr. Singh.
Thank you, sir. Yes, sir. Thank you.
Thank you so much, sir. Dr. N.K Singh, sir, it's a great evening today. And the take-home message, as sir told, that we have to look for early combination therapies, not only LDL, beyond LDL, we have to look for non-HDL things, and a little lipoprotein, little everything we should keep in mind. We have to control all the metabolic risk factors also, like diabetes and blood pressure and everything. And by this, we can definitely increase and prolong the life of our patients.
Yeah, Dr. Sanjeev.
Yes, sir. Thank you. We had a wonderful session today, and many things cropped up, many new discussions came about. And the most important point is that lipids management is the cornerstone in our treatment of prevention of cardiovascular disease. So we must be very vigilant on this. And as Dr. Gyanendra has rightly told, that we must go in for combination therapy in those high-risk patients who really deserve it. Yeah. And we should not be only LDL-centric. We should look ahead of LDL. The non-HDL cholesterol should also be tackled along with the triglycerides and all. So then we can really bring down the risk factor and give some benefit to the patients. And of course, lipid treatments have to be continued for long time, maybe lifetime. That also needs to be taken care of.
And last, I think words of wisdom from Dr. Sattur, sir.
Thanks a lot. It has been a great evening to share the platform with all of you, Dr. Medhi and Dr. Singh. With Dr. Singh, I share many platforms, but nice to be with Dr. Medhi and Dr. Singh on this platform, and hope we'll meet again and again on many events. Thanks a lot. Thanks, Sneha.
Yeah, Dr. Snehal, can you now propose a vote of thanks and end the session?
Yes. I would really like to thank Dr. N.K Singh sir for helping us put this program together, and what a wonderful session by Dr. Sattur sir, and the fantastic moderation by Dr. Medhi sir and Singh sir. Excellent questions, not just from the audiences, not just the audiences have appreciated it, but also fantastic questions from your end as well, based on your clinical expertise. So thank you very much, Singh sir, Gyanendra sir, Sattur sir, and Medhi sir for giving us yet another successful program. And we really look forward to having you on board with more such interesting sessions. Thank you once again for giving us your valuable time.
Thank you. Thank you very much, sir.
Bye-bye. Bye-bye.
Thanks, everyone. Thanks, sir.
Bye-bye. Thanks a lot.